Hi, my name is Tatyana Houston, and today I chose to talk about two interventions. One of my interventions talks about homeless individuals with mental disorders and what programs can not only help them find housing, but also give them counseling through these programs to help with these disorders. My first article on the first intervention would be Housing First improves residential stability in homeless adults with concurrent substance dependence and mental disorders. In my first article, it talks about the Housing First program in four cities of Vancouver. The study examines the relationship between substance dependence and residential stability in homeless adults with current mental disorders 12 months after randomization to Housing First programs or treatment as usual. In order to gain participants for the study, the researchers choose referral systems and the snowball system because there's no sure way to get in touch with the population being researched, which is the homeless population with mental disabilities. Participants were only eligible if they met requirements like being 19 years of age or older, met criteria for the mini international neuropsychiatric interview, and were homeless or precariously housed. The intervention in brief talked about people who were high need and moderate need. If you were high need, you were assigned to one of three arms. Housing First with assertive community treatment. Participants chose from three market lease apartments in different neighborhoods with counselors with services such as psychiatrists, counselors, nurses, occupational therapists, substance abuse counselors, vocational counselors, and peer specialists. The second arm was to congregate housing with on-site support, which is basically participants receiving their own room and bathroom in a housing facility, and they share a space and receive activity programming and various health and social services. The third arm of the intervention would be treatment as usual, which is whatever treatment they will receive if they weren't in the program, whatever the city has for them. If you were scored in a moderate criteria, you would have to be in one of two study arms. The first would be Housing First with intensive care management, in which participants could choose from three different leasing apartments and receive a caseworker who then connected them with existing services. The second arm would be treatment as usual, which is, the results of that article were that they recruited 497 participants and they found that there was no significant association between substance dependency and residential stability, which means Housing First can achieve residential stability in adults who are homeless and have mental disorders, even if they are substance dependent. Some strengths and limitations of the studies were, although there was no strength stated, some limitations were like the study included self-reported measures of substance use which might be underreported, particularly given that the baseline interview was conducted before individuals were randomized to a housing interventions, and participants might have felt hesitant to disclose the amount and frequencies of illicit substance uses. My second article would be Evaluation of Housing First programs in patients with severe mental disorders in, I'm sorry, in France, the study program protocol for a randomized control trial. The second article follows the Housing First program, but unlike the first, this intervention is set in four different cities of France. The study objective would be to assess the impact of Housing First interventions in comparison with treatment as usual. In order to gain participants for this study, they also use many referral systems and some snowball sampling. Subjects are referred from a wide variety of services, including mobile reach teams, community mental health services, general hospitals, and etc. The intervention consists of the assistant asking any questions and getting informed consent, and then the patients are randomly assigned to either group 1, which is Housing First, or group 2, which is treatment as usual. Certain evidence has provided confirming that the effectiveness of Housing First program, but the study is still ongoing. The strengths and limitations included. Strengths include the project is the proposition of a rigorous evaluation of two policy options, which means that the results are more representative of everyday practices and provide significant evidence regarding the feasibility of using the Housing First intervention. Another strength includes mixed, mixed method approaches, qualitative and quantitative. And some limitations of the study were the Hawthorne effect, which would mean the individuals become conscious of being observed or benefit from being observed, which may induce them to change their behavior. And my second intervention was on what comes after the program, meaning what type of quality of life is being brought out in these programs. Secondly, what happens when the with the housing after the program helps them get better. My first article for that intervention would be called Integrating Permanent Supportive Housing and Co-occurring Disorder Treatments for Individuals Who Are Homeless. This pilot study examines the feasibility and preliminary outcome of systematic integrating permanent supportive housing and an evidence-based co-occurring disorder intervention called Maintaining Independence and Sobriety Through System Integration, Outreach, and Networking, which is an acronym for MISSION. Enrollment criteria would include homelessness, 18 you have to be 18 years of age or older, have a current substance abuse or dependency problem or past history and concerned about relapse, reported an active mental health problem without the presence of acute psychotic symptoms or instability. The exclusion criteria would consist of you being actively suicidal, in need of immediate medical attention, and unable to provide informed consent. This single group pilot enrolled 107 people with co-occurring disorders. Co-occurring disorders and experienced chronic homelessness from two Massachusetts inner city and rural areas. And it lasted for 1 year, and the data was collected through baseline at 6 and 12-month follow-up assessments. Ooh. Results of this study were the pilot study suggested that co-occurring disorder interventions like Mission are feasible to integrate with permanent supportive housing despite the somewhat different philosophies. And there were no strengths of this study, but some limitations were this study did not include a comparison group. A longer follow-up period would have been helpful, and the outcome data collection strategy did not include qualitative data collection, which would have been helpful. My last article is on the quality of life after housing first for adults with serious mental illness who have experienced chronic homeless. That's the title. This study examines the quality of life after housing first. The intervention was basically the 1 year longitude study of adults who received transition from homelessness to permanent supportive housing, focused on quality of life as a primary outcome of interest. And it was 80 of 103 new tenants participated in structured interviews at the time of entry into their new home and at a 12-month post-housing. T-tests assess differences in community participation and quality of life measured at the two time points. Mixed effects models examine the impact of community participation on quality of life. Some strengths and limitations would be the small sample size with limited statistical power potentially explains lack of significance for a certain expected outcome. The population they took from, even though the homeless population is mainly African American, the sample is predominantly African American, which may limit the generability of the findings. And the conclusion of this article would be: despite concerns that individuals are socially isolated and struggled in unfamiliar neighborhoods where they have no social ties, Housing First tenants living in scattered site apartments either experience an increase or no change in various domains of quality of life. Overall participation in community activities remain limited but appear to have limited impact on quality of life domains. Instead, interventions that reduce symptoms severity and increase financial resources may have a more direct impact on quality of life. The intervention that would best address my topic would most likely be the Housing First intervention. It would be the Housing First intervention. It not only helps homeless people with substance abuse and mental disorders get off the streets, but it also gives them counseling, jobs, and access to medication, programs, and psychiatric help they deserve and most desperately need.